You will not force.
So, TAVI really is a team game, and this is an opportunity to recognise the components of that team. Cardiologists, and you're going to hear from my colleague Raj Kharbanda, anaesthetists, you're going to hear from Kate, cardiac surgeons, and George and Rana are here, geriatricians, Kushar, but actually also the broader hospital, our vascular surgical colleagues over there, thank you very much for what you do to help us in our moments of need, interventional radiology, and ultimately the cath lab team, who have combined over the last 10 years really to transform something which was really, and it's extraordinary. 15 years ago, I could not consider that we would be doing this now, and that's really quite, coming from someone who's reasonably optimistic that there will be progress. This really is a totally transformational technology. It has been a roller coaster, and one of the things that's inevitable is that it is unpredictable. And to bring forward a new technology where really the clinical trials showed a death rate in the treatment arm of between 5 and 10%, but in the conservative arm, we were looking at a death rate of nearly 30% at 6 months. So this is an extraordinary technology which ultimately had no funding at all 10 years ago. But suddenly we produce a technology which can treat a completely previously untreated population. How do we take that technology forward, and how do we find the funding, the resource and the time to treat this new population? So Raj is going to talk to us about what is TAVI and who should have one. I'm grateful to Kate, who's going to talk to us about the anaesthetic considerations for putting in a new aortic valve in a patient of over 80 while they sit and talk to you. I mean, that's literally how it happens. And then I'm going to talk with a few slides about how we've integrated our clinical teams with this new technology, how the UK has taken to this technology, and how data shows us how unit outcome can be monitored. And we might then have a bit of a discussion about the funding and logistics of new technology going forward in the NHS. What's done well, what's not doing well, and how do we square the round? Raj, thank you very much indeed.
Thank you very much. So for an audience like this, aortic stenosis is probably something they encounter but don't really recall. But it is a disease of the elderly. Okay, so this is degenerative disease. Symptomatic aortic stenosis is lethal, and surgery is the standard of care. But by the very nature of patients we're dealing with, they are at high surgical risk with complex comorbidities. So that balance of benefit and risk is really quite an important decision in these patients. Having said that, surgical aortic valve replacement in the UK carries a very good outcome, and in most units would have a predicted 2% mortality rate, and that remains steady. But the problem is, as you see on the right, there are many patients with aortic stenosis who do not get surgical intervention. And that is the patient pool that we primarily targeted initially. So it's a good surgical procedure, but many patients aren't getting surgery because they're not fit enough. So TAVI, as you've heard, is transcatheter aortic valve replacement, and across the pond they call it TAVR. The first procedure was performed in 2002, and at that stage it was a compassionate procedure performed in a man. And the approach taken was to go up through the IVC, puncture the intraventricular septum, go through the mitral valve, and go antegrade up the aortic valve. And that was a proof of principle, and that's why it got published. The patient survived the procedure, and as you can see on the last line, it says percutaneous heart valve might become an important therapeutic alternative. And that was in 2002. And what happened in the subsequent 10 years is that we had 2 and 3 large randomized trials looking at patients either who were too high risk for surgery, i.e. they were medical therapy, or patients who were considered high surgical risk who were randomized. And what both of those trials showed is that TAVI was superior to medical treatment in patients, and that it was equivalent to surgery in terms of outcomes, and these were hard outcomes, in comparison to high-risk aortic valve replacement. And then depending on your trial, it can become very much better to have this done percutaneously rather than as a surgical procedure. And these are Neil Moat's prophetic words in his editorial following the publication of the second trial. So there's a consistent message that TAVI is non-inferior to surgery in terms of early and mid-term mortality and is likely to be superior if we can access the valve and deliver the valve percutaneously with a transfemoral approach. And I think that's where the sort of the direction of travel is. So we haven't got trials in the very low risk group, and we get often asked about this, but low risk is still ongoing. And currently, and Adrian will, I'm sure, touch on this, is that some of the funding issues, although intermediate risk are now recommended, we don't have that funding and commissioning. So currently, these are the indications for patients who are eligible and get TAVI in Oxford in 2017. So they have to have symptomatic aortic stenosis. That sounds rather churlish, but that can be a fairly difficult diagnosis to make. They have to have an expected quality of life that's going to improve, i.e. aortic stenosis has to be the dominant pathology. So if they're demented with significant comorbidities, this is a complex. Is there a clinical contraindication to surgical AVR? And then what is the surgical risk score? So those are the two criteria that we currently go by. As I've said, and this is a graph from the original partner trial, the mortality, this is mortality, remember, of patients with symptomatic aortic stenosis at 12 months is nearly 50%. And with treatment, that drops down to 30%. So this is an effective life-saving intervention. This is the current pathway, however. And what you see is that the current, not necessarily in Oxford, but this would have been the sort of traditional pathway, i.e. a patient would be investigated locally, get referred for an operation, the surgeon says, I don't think you're a surgical candidate, and by that time, there's quite an attrition. Okay, so what is a TAVI and how is it done today? So the patient's awake, it's done a local anaesthesia, it's fully percutaneous, same day admission, often to the heart centre. They go back to the day case unit and then don't even need to touch a high intensity monitoring bed. And those processes are getting slicker and are likely to be better as we deal with lower risk patients. So it's done usually via the transfemoral route, although if we have difficulties with vascular access, we can access this via a transapical route, a minimally aortic access route, subclavian axillary, which we haven't done in Oxford, or transeptal. And those are surgical approaches, really. And then we deploy the valve. And there are various kinds of technical aspects of valve deployment. So we have evolved the service. And I think it's quite important, historical and institutional learning usually only remembers the bad things, but we have evolved the service. And the service has been going since 2008. And originally, it was a big procedure. It was a big surgical team. It was a big cath lab team. We had a perfusion circuit. We had the surgical scrub team. All these procedures were under general anaesthesia. It was a surgical cut down to the groin. They all went to CTCC, intensive care monitoring, and they stayed in hospital 7 days. That was a 14-person team with 2 cases a list, with scheduling was difficult because you had to arrange half the world's diary, and we couldn't do urgent cases. Since 2014, we've changed that. We've cut the team down. We've developed new techniques and adopted those and developed a percutaneous approach with sedation. The mean length of stay is nearly halved, and we use percutaneous closure devices. We had a learning curve with those, but now we're routinely doing 3 to 4 cases on each list. We can do urgent cases, and the workflow is considerably different. So this is the patient awake. Kate's taking the photograph. She's off screen there. And the patient is on oxygen, remifentanil running, and she'll talk to you about that. We now do these procedures under ultrasound guidance. We've learnt that that is a safe and effective way to access the femoral artery in these patients. This is a very clean femoral artery, but this is a good example. They're not often this healthy. And we don't pace routinely, so we've really minimalised the procedure. And what we do is from the femoral artery, past this catheter, which is the size of a large fountain pen, across the descending and thoracic aortas, across the aortic valve on a stiff wire, and deploy the valve very much like a stent. And here you see that. So in the top left, that's the valve being pushed across the aortic valve. We check that valve position and release the valve. So that is an aortic valve implantation through the transfemoral approach. We close the arteriotomy, and that procedure for curing aortic stenosis is delivered now in less than an hour in most of these cases. So this is, as Adrian says, a transformative technology. That's post-procedure, and we're planning to discharge these patients on day 3. So it's a very, very different journey for these patients. And this is increasingly the sorts of cases we might be dealing with. So 82, heart failure, severe aortic stenosis. This would be a high-risk surgical candidate. To pull this patient through conventional surgical aortic valve replacement would be challenging for the patient and the institution and everything else that goes along with that. So TAVI is ideally designed for these sorts of patients. So these are the currently quoted risks. And remember, the things have evolved. This is dealing with originally the very, very highest risk surgical patients, and figures in current trials are considerably better than this. So we've done just over 500 now. We were looking at our figures yesterday. We've done 520 TAVIs in the Oxford programme over that time. About a third of those have been through the surgical non-transfemoral approach. The transfemoral, we've predominantly used the Lotus valve, which is just one of the technical valves that we can use. We're the largest implanters of this in Europe. And there are a range of other valves available. 250 of those have been done fully percutaneously, the majority with sedation rather than GA. What this doesn't tell you is how many patients we filter through. So there is quite a rigorous process. And of those that we have treated, about 1 in 3 that are referred actually gets a TAVI. And that's the rigor of the MDT, the fact that we all sit in a room early on a Thursday morning and critically ask the question of, are we doing good here? Is this the right intervention for the patient? In association with quite a thoughtful process, I think. And I think that's reflected in our outcomes. We're not taking away work from the surgeons. This is national data. And what you see is a trend in increasing use of biological valves, because the cohort we are treating is a more elderly cohort, and biological valves are used generally in that cohort. And the top slice of this is the TAVI programme increasing there, as you see, over the past years. There's an array of valves, but the future is bright, and it's really understanding how we deliver that within the constraints of our current systems. And good anaesthesia and good control are really important to that. And that's why Kate is going to tell you next about how we achieve some of these outcomes.
Okay. Thanks very much. I have been fortunate enough to have been involved with the TAVI team right from the very first implant. And Raj has already stressed the enormous progress that we've made along the TAVI pathway. And it seems like a long time ago, really, that we were doing these cases under general anaesthesia. I think the important thing is that at the time, of course, all the patients were going to the ICU post-operatively. And so not only were we struggling with, as Raj says, all the problems of getting this huge team together, but not such a big team there, actually. but we were also competing with the cardiac surgeons for post-operative intensive care beds. So when we started to move over to using self-expanding valves, we decided to progress to using sedation rather than general anaesthesia. And there are lots of very obvious advantages to doing these patients under sedation. For me, predominantly, it's that they're much more hemodynamically stable, because if you think elderly patients with multiple comorbidities and critical aortic stenosis can be quite problematic for anaesthetists to deal with, so that the hemodynamic stability is much better when they're awake. I'm no longer hosing in noradrenaline to keep a reasonable blood pressure. It's quicker, it's cheaper. We don't have figures for the less confusion, but we know that the patients are going home more quickly, and we're all aware of the amount of confusion that general anaesthesia can cause in elderly people. We've reduced our post-operative stay, and I think very, very importantly, we're no longer competing with the cardiac surgeons for intensive care beds, and that is an very important consideration. But there are problems, of course. The patients can move about. We don't have transesophageal echo. Some of the patients are a bit alarmed at the thought of being awake for this, although elderly patients are usually quite stoical, and they're quite when you explain to them about it, they do take it on board. You do need very good local anaesthetic infiltration. And one of the very important things that actually most cardiologists didn't seem to know, and I suspect quite a lot of surgeons, general surgeons, don't know, and that is that local anaesthesia doesn't work instantaneously. So you do need to give the patients, you do need to get good local anaesthetic infiltration in layers and give the anaesthetic time to work. And that's been particularly important since we've moved over from using 1% lignocaine to using 0.25% bupivacaine. And the reason for that was that actually the cardiologists were administering in hugely toxic doses of lignocaine to these elderly patients, some of whom are very small and frail. And although we didn't actually see any clinical problems from local anaesthetic toxicity, I was quite concerned that if we did, we would be open to considerable criticism. There's also, of course, the possibility for needing to convert to a general anaesthetic if things go wrong, and I'll talk about that in a minute. I mean, as a cardiac anaesthetist, I haven't had much call in most of my career for doing cases under local anaesthetic and sedation. So it's been a real learning experience for me doing this. And one of the things that I've realised is terribly important is to go and talk to the patients beforehand and tell them what the expectations of the procedure are. There is good evidence to suggest that patients are very influenced by the language that you use beforehand, and I would say this is not a painless procedure, but if you talk to the patients and you try to use non-emotive language, there is good evidence that patients' perceptions are very influenced by what you tell them they're going to feel. So I try to talk about tingling from the local anaesthetic, about pressure and pushing in the groin rather than pain and stinging and bee stings and all of that sort of thing. So I try to explain that they will feel a lot of curious sensations, and some of these may be uncomfortable, but I try to avoid emotive language. And I also tell the patients that we can't do it if they wriggle about, so that our expectation of them is that they're going to keep still. One of the things I've learned is that it's best to keep the false teeth in, because when they are lying flat and sedated, they maintain their airways much better with their teeth in. But the other thing is that you want to be able to talk to them. And if you've got elderly patient lying flat without their teeth in, with an oxygen mask on, partially sedated, you'll never be able to understand what they're saying if they haven't got their teeth in. Similarly, for hearing aids, you do want them to be able to hear what we're talking about and what we're saying to them, particularly when we're shouting, "Keep still." But I also warn them they're going to hear a lot of conversation during the case, and particularly when Raj is scrubbed, that they might hear a lot of laughter and joking, and not to worry about that. It is important to get them very comfortable. I think having a bear hugger underneath them so that they're warm and they're cosy. I try and put a pillow under their knees because a lot of these people have got arthritic joints and they can't actually lie flat. I try to get them in a really comfortable position. Some of them are very anxious about lying flat because they're obviously orthopneic. But when you give them the sedation, one of the advantages of using remifentanil as a sedative is that it reduces your respiratory drive. And I think that does help with some of the very breathless patients. They do find it easier to lie flat when they're having remifentanil. And I just accept that they are going to be rather hypercarbic during the procedure, but so long as they're not hypoxic, I'm not worried about that. I mean, remifentanil is a fantastic drug for sedation. It's just a little bit tricky to use because if you give them too much, of course, they stop breathing. But I have got, again, much better at doing that. And I think the sedation has improved over the years as I've got more used to doing it. If the patient's very restless, there are three options. You can actually deepen the sedation, which I don't recommend. It doesn't work very well. It's usually better to lighten them and find out get them to tell you what the problem is. And often it's just that the local anaesthetic isn't actually adequate. And of course, you can always convert to a general anaesthetic. And I've had, out of the 166 cases I've done under sedation, I've only had 4 general anaesthetic conversions, and only one of those was for a real catastrophic emergency, and only one was for a sedation failure where the patient kept moving his legs, and I thought that Adrian was going to kill him if I didn't put him off to sleep. Post-procedure, Raj has said the patients go back to the daycare unit, and we keep an eye on them for the first couple of hours for the complications that may occur. But they are back to the ward very rapidly, and it is wonderful to take a patient off the table who's just had an aortic valve replacement and say, right, I'm taking you through, going to get you a cup of tea now. It's not like that with surgical AVR. So there are quite a few challenges for anaesthetists. I mean, it is a distant and difficult environment down in the cath lab. You can't get to the patients very easily. There's a lot of equipment down there. These are elderly, frail patients. We're doing very complex things to them. There's a lot of hemodynamic compromise at different points in the procedure, and there's always the possibility that something's going to go wrong. And when things go wrong in TAVI, they do go wrong very, very rapidly. There are places however, who do them without an anaesthetist. And I think at the moment, I'm probably still needed down as part of the TAVI team. I hope that I can contribute to reducing some of the complications from TAVI, and hopefully I can be of assistance on the occasions when things actually go catastrophically wrong. So I suspect that actually perhaps having an anaesthetist there, although there may be selected cases you could do without an anaesthetist, if you want to keep your results consistently really good, perhaps having an anaesthetist there is the secret to that. We've all learnt a lot along the TAVI journey, and that's just, one of the things that we've learned. Thank you.
As we've seen, this therapy is totally transformational. This patient was treated, he came over from the Falklands to Oxford. That's him on the left, pictures taken by his family, on dobutamine. He'd been on dobutamine for 2 weeks before being transferred via Brize Norton into Oxford. And this was him on his way home, going back to the Falklands. We've treated patients from Calgary, and we've done over 500, as you've heard. It's been humbling to meet some extraordinary elderly people. This chap's over 80, and this is his bavy. This is how he gets his electric bike now, as he's had his TAVI into the car so he can go cycling around Port Meadow. You do get a nasty bruise. This slide illustrates the fact that actually in older people, anything you do can cause a nasty bruise, and that's a nasty bruise caused by the TAVI there. Not quite as bad as the nasty bruise you got from the pacemaker at the same time. So everything that you do really is you're walking on rather thin ice, and you need to do things very, very carefully. We've heard that the number of procedures we're doing with the same team actually has gone through the roof. So we're doing 3 times as much as we were 2 years ago. And the rate of referral for patients for consideration of TAVI is really, so the procedure itself is really the iceberg. There's a massive amount of work that we need to do to make sure that we're doing the right patients at the right time. Our results are really quite extraordinary, I think, and as you've seen, we've gone forward with the way in which we assess our patients, and we're now regularly quoting, although we continue to quote a 5% mortality, our outcomes really are very much better than that. Urgent patients inevitably will have a higher risk, and that's partly to do with the challenges of assessing patients who've been in hospital for 2 or 3 weeks, and that other comorbidities sometimes catch up with them subsequent to successful TAVI. We're part of an extremely productive research group, which is the UK Interventional Cardiology, and we're part of this trial, which is a randomised trial of TAVI versus high-risk surgery in elderly patients, and as you see, we're recruiting very well to that. So these data are UK data for outcome, 30-day mortality. This is year before last. That red curve is a projection as to what you should be achieving. As I've mentioned, mortality is a very real possibility in patients with TAVI. And through BCIS, we've been able to track outcomes of units in these new this new technology, and to see that everybody's really delivering the results of the clinical trials suggest that this expensive technology is valuable. This is the most recent data with death in the red on the left-hand side there and vascular complications. These are the units currently doing TAVI. And as you can see, Oxford really is very much in the top, at least in the top 25%, if not top 5% there. And last year in Oxford, we did more TAVI than the whole of Scotland. Scotland only has 1 unit, and we outperformed them with regard to numbers of procedures done. So what are the issues for us? Well, as you've heard, there's an awful lot of interest in what's the best technology. Pacemaker rates are a problem for us. Most of these elderly patients with aortic stenosis have extensive subclinical conduction disease already. And it's not a surprise that pacemaker rates are high, and they are in surgical AVR, but it is a problem. Managing our waiting list is extremely challenging. And the commissioning, I think, is problematic, as I mentioned at the start. Ultimately, this is a new therapy, a new patient group, which there was no funding for 15 years ago. And now we are performing 150 procedures a year. We're scheduled probably 200 this year, I think. And the administration and the management of these patients needs to be prompt. Inevitably, patients are anxious, but the family are even more anxious about the waits that are incipient in the process of assessment, which needs to be stringent and needs to be careful. I'm going to finish up just by thanking again the team that we work with, our cardiac surgeons, our anaesthetists, our vascular surgeons who back us up, and the rest of the hospital, who ultimately will come into contact with TAVI patients increasingly. It's been a journey which will continue. Thank you very much.